Everybody. And yeah, welcome to this session of Therapy Ed's online office hours. Um, this evening, we're going to be talking about differential diagnosis of conditions that can masquerade as musculoskeletal pain. And as you probably already noticed in the chat box, just a reminder, if y'all could make sure um, to mute your microphones when you enter the Zoom room. And this session is going to be recorded and it'll be posted to Therapy Ed's PT YouTube channel. It usually takes several days for that to happen, uh, but it will be posted there along with a number of the other online office hours sessions. And just real quickly, let me go ahead and introduce myself. My name is Tom Sutlive. I'm on faculty in the Army Baylor University program here in San Antonio, Texas. As a matter of fact, I've been on faculty within the program for coming up on 25 years now. Before that, I served on active duty in the Army as a PT for 23 years, and you can see some of my background and education and credentials and everything there. Um, Right now, I teach primarily the anatomy and foundational sciences in the program. I had gone back to school and got my PhD in anatomy. And since 2011, I've been an instructor with therapy. So, teach the 2-day prep course, and over the past several years, I've also been a one of the co-editors for the Therapy Ed Review and Study Guide that I assume a number of you are familiar with it. And yeah, I love what I do. I enjoy working with students like yourselves, and um, I'm looking forward to the next hour or so that we're going to spend together. And if you would go ahead and light up the chat box, and can you go ahead and let me know when you're planning to take the NPTE? And yeah, just go ahead and all right, Brandon. So I see a number of you going to be taking the examination in a week or within the next couple of weeks or so. That looks like most of you. Some of you are not taking the examination until later in April or in 2025. And so awesome. So spooky on October the 30th. Okay, I see that. Yep. So perfect. So that gives us a good idea uh, about the folks in the audience and everything, and we'll talk a little bit more towards the end about the final online office hour sessions that we have coming up, and yeah, so most of you are going to be a couple of weeks away. So let me tell you a little bit about what we're going to cover tonight. And this is, um, yeah, the whole premise for this, and this idea of masqueraders of musculoskeletal pain, at least historically for me, probably goes back to the early to mid 1990s. And I was reading a book called Manual Modern Medicine or Modern Manual Medicine, and it's a book by Gregory Grieve, Grieve. Actually, there were a few different volumes to it, and um, there's a chapter in that book that talked about masqueraders of musculoskeletal pain. And I don't know if he's necessarily the person, if Grieve is necessarily the person that coined that phrase, but it's catchy. And so what we're going to do this evening is talk about some of these smaller body systems that you're going to be responsible for on the examination, and in particular, the medical screening and differential diagnosis of a number of different problems or a number of different disorders that can actually masquerade as musculoskeletal pain. And we'll do that by really having you answer a number of questions. I think I've got 5 or 6 questions that are lined up. And what we're going to do is after you answer each question, we're going to review the material. And again, some of the important information and principles that I think it's likely that you'll be tested on coming up with the NPTE. I think it's always helpful, and for those of you who are going to take the exam in October, no doubt you're very familiar with the content outline that is presented on this slide. This is the one that went into effect in January of this year. And so for the musculoskeletal system, we know that that's the system that comprises the largest percentage of questions on the exam. So as a single system, you should plan to see if we kind of find the midpoint. If you look at the far right column and within the red box, it says that you're going to see anywhere between 44 to 54 questions related to the musculoskeletal system. Well, smack dab in the middle of that range is going to be 49. So you can probably expect out of the 180 questions that you're going to be graded on, that about 50 of those are going to deal with the musculoskeletal system. And then there's what we refer to as the big three. So not only the musculoskeletal system, which will comprise about 27% of the exam, but also the neuromuscular systems and the cardiovascular and pulmonary systems. So certainly the big three is going to be a priority for everyone in terms of preparing for the exam, with the musculoskeletal system leading the way. So these big three systems comprise 65% of the questions that you'll be graded on the NPTE. Said another way, that's 2 out of every 3 questions on the NPTE are going to be related to one of these 3 systems. But we still need to do sufficiently well on the smaller systems, and that's what I've presented to you on this slide. And if you do the math, kind of the percentages may be off slightly. Again, I'm going to go back a couple of slides. The NPTE doesn't tell us precisely or exactly how many questions we're going to see on each system or on each category. They give us this range that we see over here on the right-hand column. And so we kind of guesstimate as far as the percentages go a little bit, but the information that you see on this slide, it's going to be within like 0.5%. So it's going to be pretty accurate. So yeah, we got these smaller systems. And again, we will need to do sufficiently well on these in addition to the big three in order to pass the NPTE. Now, take a look at this. Yeah, take a look at this slide, and we can see the systems listed at the very top of the slide. But then in the left-hand column, it's that bread and butter stuff that we do as PTs. We examine the patient, right? We do a history and we do a test and measures. That leads to our assessment, our evaluation, differential diagnosis, and prognosis. And then we treat the patient, right? And those are kind of the non or some of the non-system categories that we're gonna see on the exam. So we can take what this table shows us is a combination of the bread and butter stuff that we do as PTs and the smaller systems that we have listed up at the very top. Now, as you take a look at the table, you'll see there are some zeros, like there's a 0 right here under metabolic and endocrine. There's one under system interactions as well, and another one down here under system interactions. And the reason why there's a 0 there is that we do not have like a special test or a historical question that is kind of that we do as part of our PT toolkit that leads to the diagnosis of Graves' disease, for instance, or that leads to the diagnosis of diabetes. That is, there's not like a Lockman's test or an anterior drawer test that leads to the diagnosis of Graves' disease. But what we do need to do is we need to be familiar with the characteristics and features of the diseases. We need to be familiar with the signs and symptoms of a number of different disorders that affect these smaller systems. And that's really, as far as questions on the NPTE, it's this middle row where we're going to see questions that deal with signs, symptoms, characteristics, and features of disorders that would really lead to a diagnosis of whatever that problem is, right? And recognizing it. So the reason that I have this box highlighted, and hope you can see that it's kind of the red against the burnt orange background, but hopefully you can see that there, like where the laser pointer is, far and away for the smaller systems questions on the NPTE, they're going to deal primarily with differential diagnosis. So if we total up all the numbers on this slide, that's what I've done here with these bullets. What we're going to find is there's about 37 out of the 180 questions that you'll be graded on that deal with the smaller systems, and 20 out of those 37 are going to be based on differential diagnosis. So you all know the examination that you're taking is going to be textbook based. And there are a couple of really good textbooks. I have one here. I don't know if it's going to get, yeah, it's kind of blurred, but it's Goodman, Hike, and it's Goodman and Snyder's Differential Diagnosis for Physical Therapists. The editors are Hike and Lazaro. There's also Boysenalt, Medical Screening for Physical Therapists. That's a good textbook that relates to these categories. But let me just repeat that, yeah, it's more than half of the questions on these smaller body systems are going to be related to evaluation, differential diagnosis, and prognosis. And that total is going to represent about 11% of the entire NPTE. So that's not a huge number if we compare it to something like the musculoskeletal system, which is 27%, but it still represents a pretty good chunk of the exam. And we need to be prepared for questions that address these small systems and these topics. And so for the smaller systems, dedicate most of your energy, most of your study efforts on your ability to recognize features and characteristics or signs and symptoms of diseases that affect those systems. Still got to know how to treat them, and we still want to, make sure that we recognize the appropriate PT examination history, tests, and measures that apply to a number of the systems. But you get the point where I'm going with that, and where most of the questions are going to fall in these categories. And what we also want to remember is that that there's a huge emphasis on safety, right? There's going to be a huge emphasis on safety on the NPTE. Now, if you look at the NPTE content outline, I think that it says that there's about 6% or 8% of the questions deal with safety. I think that may be a little bit misleading from the standpoint that that it's probably saying that they're going to be, from 6 to 8% of the questions that deal with that are very deliberately safety based. Like if a patient falls in your clinic, what are you going to do? Or the questions will test your knowledge of standard precautions or universal precautions, or how to administer CPR, something like that. But you could get a question on autonomic dysreflexia, so somebody that has had a spinal cord injury, and the question is classified as a neuro question or a neuromuscular question, but you can bet that there's going to be a very strong safety element to how you manage that patient. Or you could get a question about a patient with a cardiovascular condition, a cardiac condition, and it deals with, again, intervention or treatment of that patient. But most of those questions that deal with the cardiac system, there's going to be a pretty good element of safety and making sure that we safely manage that person with heart disease and in a proper way. So similarly, as it relates to the topic tonight, we've got to be able to recognize red flag conditions, right? We got to be able to recognize when that person that has back pain, maybe it's not neuromusculoskeletal back pain, mechanical back pain. Maybe that back pain is actually emanating from one of that person's organs. They've got some kind of disease process that is affecting an internal organ. So again, there's this element of safety and being in tune with red flag conditions and recognizing signs and symptoms in that regard. So what we're going to do is we're going to go ahead and answer some questions, and then we're going to review some content along the way. I'm going to give you about a minute per question. You're actually on the examination that you're going to take. You're going to end up having about, let's see, I'm trying to find my poll here. Yeah, the questions, the polls. Yeah, so let me find this real quickly so I make sure I got this and we're ready to go. But you're going to have about a minute and 15 seconds on the actual NPTE on average per question. And so, all right, so I'll give you about a minute to answer each question. And about 30 seconds into the question, you're going to see a poll that'll pop up, and you can go ahead and start chiming in with your answer. And then we'll review the content, we'll review the questions, and then we will, then we'll talk about some information or review some information that is going to be important, not only in terms of answering the question, but important to review ahead of the NPTE. All right, so here we go. Here is question number 1. Yeah, so Brandon, I'm sorry, don't put your answer in the chat box. I'm going to give you a poll, and you're going to respond to the poll. As a matter of fact, here we go. Y'all should see the y'all should see the poll right there. Okay. All right, go ahead and take about 10 or 15 seconds to get your answers in, and then we'll review the question. All right, so I've got some we got some words that are going to be highlighted here, and this patient is well known to the PT clinic. They've been seen for chronic neck pain for for a period of time. And let me go ahead and share the results of the poll with you. But this patient that is well known to PT, they're being treated for chronic neck pain. They now have this new complaint of acute mid-back pain. And their symptoms also include abdominal pain and distension, uh, and that often intensifies soon after meals. Um, Person also reports taking 5,000 milligrams of acetaminophen daily for 2 weeks. That's a huge dose. So the guidelines or the limits for taking acetaminophen in a day are going to be 4,000 milligrams. Not too long ago, it was actually 3,000 milligrams, but I think within the last few years, they bumped that up and said that 4,000 is safe. But this person has exceeded that, and they've been taking it daily for 2 weeks. And so with all that, and most of y'all said that the correct answer on this one is number 3, or C, and that is indeed the correct answer. So I don't know if y'all were biased by Brandon responding. And Brandon, no worries, we got plenty of other questions that we're going to answer, and we'll just make sure that we save our answers for the poll when I get that launched. But yeah, this person likely they've got this acetaminophen toxicity, and that is leading to pancreatitis, and the clinical presentation, the abdominal pain and distension, radiating pain or referred pain to the mid-back is going to be consistent with pancreatitis. So this is an image from our review and study guide, and it just shows it's actually from an old reference, the Rehabilitation Specialist Handbook that was published a number of years ago. And you'll see different pain referral maps, but I think most of them are going to be fairly consistent with one another. And you can see at the tip of the green arrows, where we often see, patients complaining of pain related to the pancreas. So on the posterior side of the body, on the right side of the slide, kind of that mid-back pain, that area. And we can see that, we can see that again right at the tip of the green arrow. So certainly you want to be familiar with pain referral patterns. That'll be important going forward, not just for the NPTE, but obviously for your clinical practice as well. And we're going to do just a quick we'll do just a quick review. There are a number of different ways that pain can be referred from the viscera. One of them is, and I think this is what we most often associate with pain referral patterns. And remember, with the pain and temperature pathway, you might have learned this as the anterolateral system, or you might have learned it as the spinothalamic tract or the lateral spinothalamic tract. But we can have first order neurons in that pathway that converge onto second order neurons, and those first order neurons came from different areas, but they converge on second order neurons in the dorsal horn of the spinal cord, and then relay that information all the way up eventually to our somatosensory cortex, where we perceive the pain. But in this first idea that there are shared pathways, pain can be referred to areas innervated by the same nerve pathways. So a classic example would be if there's pressure that is exerted on the diaphragm, for instance, from the spleen or from the liver or from some other kind of pathology. Well, what do we know about the innervation of the diaphragm? There's that saying, C3, 4, 5. C3, 4, 5 keeps the diaphragm alive. And so where are the C3, 4, and 5 dermatomes? C3 is going to be up here, C4 kind of right on top of the shoulder, and C5 over here on the lateral shoulder. If any of you all are like me, and you haven't run for a while, and I go out and run and I get that stitch in my side and that kind of cramp on the side, and often that's typically going to be on the right side that we get that. That's thought to be diaphragmatic in nature. Well, in addition to getting that stitch in my side, what I often do is get this kind of vague right-sided or right shoulder pain that goes along with it. So that'd be an example. This is going to be an example. We're going to talk about something else in just a minute. We're going to talk about Kerr sign. That would be another example of where we have this shared pathway pattern of referred pain. The second one there talks about embryologic development. So pain is referred to a site where the organ was located during fetal development. For instance, thoracic organs actually started out as part of the gut and often refer pain to the abdomen. What we often find, and what this can explain, is why in patients that have pneumonia or patients that have pleuritis or pleurisy, it can often be perceived, they often complain of abdominal pain in addition to or instead of in the chest, at least early on during the disease process. And then there's the idea of multi-segmental innervation. So we know that for the person that is having a heart attack, in that individual who is having a heart attack, that the classic pain referral pattern is to the medial side of the left upper extremity, or maybe down into the forearm a little bit. But we can also get jaw pain. We can also get not only left-sided or central chest pain, but it can be over on the right side. And the reason for that is because of the diverse innervation of the heart. We've got parasympathetic innervation, we got sympathetic innervation, we've got pain receptors that innervate the pericardium in particular. And so we can see kind of a diverse presentation in patients who are having heart attack, and that would be based on this principle of multi-segmental innervation. You can see the reference down at the bottom. There's an awesome chapter in Differential Diagnosis for PTs by Heike and Lazaro that talks about viscerogenic pain patterns. So in this case with the pancreas, so Kelsey, what I see you asking about, does this map change with women? Well, for the purposes of the pain referral patterns that you're going to expect to see on the NPTE, I don't think you're going to see too much of you shouldn't anticipate too much of a gender difference. So this map that I presented to you before shouldn't change too much between the two genders. Now, there certainly can be some gynecologic conditions, some pelvic organ conditions that they may, obviously those will present a little bit differently than what we would see in men, just like, in men, a man who is suffering from prostate cancer would have a fairly unique pain referral pattern. But otherwise, I think you'll be safe learning the pain referral patterns as what is presented here on this slide, and then what you may see in the textbooks that I mentioned, Heike and Lazaro, or the Boysenall Medical Screening for Physical Therapist textbook. Just a couple other information slides to go along with this question. It's been estimated that visceral disorders account for about 2% of patients seeking primary care for low back pain. So at first glance, that doesn't sound like a whole lot, but that means 1 out of every 50 patients seeking primary care for low back pain, that the estimates are that their back pain is not musculoskeletal in nature, it's not neuromusculoskeletal in nature, it's of some type of visceral origin, right? And granted, it says that it's talking, this study was done based on individuals who are seeking primary care for low back pain. Not all of you are going to be working in a primary care setting. Some of you are going to be working in a primary care setting or a direct access setting. As a military PT, I worked in a direct access setting pretty much on a daily basis during most of my career. And so, you think about in a busy outpatient orthopedic clinic, you know, 1 out of 50 patients with low back pain. Well, 50 patients with low back pain, we could easily see 50 patients with low back pain in, in a few months, in 3 months, 4 months, 6 months, something like that. And uh, so again, we've got to be good at recognizing these signs and symptoms of low back pain of a visceral origin. And we got a couple other questions that are coming up that'll help us get our reps in tonight and keep our antennas up for these kind of conditions as well. All right, let's move on to number 2. Okay, and here's the poll. You can start going ahead and chiming in with your answers. And okay, take about 10 or 15 seconds to get your answers in. All right, and I'm going to go ahead and share the results with you. And I would say, let's see, the question is for any visceral problem, the best choice is going to be to refer. Is that correct? And I would say, yeah, certainly if somebody that has, somebody that we're pretty confident about, or that we suspect that they have pain that is of a visceral origin. They're going to need to see a primary care provider. They're likely going to need to see a specialist. So certainly, if you get a question like that on the NPTE, I would probably look for that as an option. On this question, so it says that the PT examines a 63-year-old male patient. And let me just go ahead and comment right here on this. This question actually specifies the patient age, and it also specifies gender. Most of the time, what you're going to see on questions on the NPTE, most of them are going to say something like an adult patient, right? And they probably won't bring in age and gender, and maybe there's a little bit of a difference with that with the exam that y'all are going to take that started in January of this year. But generally, if you see age and gender referenced, then that's probably going to be an important part of helping you answer the question correctly. So that's kind of some of those key words that I would pay attention to. So for instance, if a question is about a 8-year-old boy who has an antalgic gait and is complaining of hip and knee pain, we're probably going to start thinking about Legg-Calvé-Perthes disease, or maybe if it's a patient that's a little bit older, maybe we're thinking about slip capital femoral epiphysis. All right, so keep your antennas up. If you see age and gender mentioned, that's probably going to be those are some key words you're going to want to tune into. This person has a chief complaint of low back pain. It's described as throbbing. No specific factors aggravate or ease their pain. And that's unusual, isn't it? For patients that come into a PT clinic with a diagnosis of low back pain, they can typically tell you it feels better when I do this. It feels worse when I do that. So they identify these ags and eases or aggravating and easing factors. It also says the therapist is unable to change the patient's symptoms with any type of position changes, functional tests, or other measures. What we're seeing here is, and the picture that is being painted is this patient's symptoms are constant, right? They're not changing based on the examination. They're pretty significant, 7 out of 10. The patient can identify ags and eases, again, relatively constant pain, and it's described as throbbing. And so most of y'all chose number 2 is the correct answer, and you are correct. And what you didn't have to necessarily come up with a specific diagnosis on this one, but y'all go ahead and light the chat box up. And what do you think might have been going on with this patient based on the description that is here? Any specific diagnosis that comes to mind? So yeah, I see a number of people saying AAA, so an abdominal aortic aneurysm, and that is exactly what we were going for. Sometimes what I see when people answer this question, they say, well, it sounds like it might have been cancer. They got the question correct, but they were thinking, well, maybe they had a tumor, like a metastatic lesion of the spine. Potentially that could lead to some of the same symptoms and everything, but I think that throbbing descriptor in particular, or when we hear about something that is pulsating, right, that makes us think of something that is vascular. And indeed, an abdominal aortic aneurysm is exactly what we were going for. So as I take a look at how everybody responded in the poll, so a couple people were thinking number 1, and if you were thinking number 1, then you were probably thinking this was a musculoskeletal problem, but that's not what we were going for. And then, so several people chose number 4, recommend an X-ray to rule out a possible lumbar spine fracture. Hey, I tell you what, if this person had a lumbar spine fracture and we've got them kind of moving around, it says, we're doing all these position changes and functional tests and those kind of things, we probably would have lit that patient up, right? We would have really aggravated their symptoms, but we're not seeing any changes in this 7 out of 10 pain. So yeah, an abdominal aortic aneurysm is what we were going for here. And certainly the person can have abdominal pain, like it shows on this case study, that the image that was taken from this case study from Josh Van Weingarten, who was he's an Air Force physical therapist that I know, and this study was published in JOSPT, and he was the first person to pick up on the fact that this patient had a AAA, and it refers pain to the low back. And that makes sense, right? Because as we can see from this, in this paper, another JOSPT case study that was published in 2008, in this CT, and we'll just review the anatomy here. We can see the heart, the aortic arch, the descending aorta. We get down here, that is not the stomach, right? That's the aneurysm that we're looking at. We've got kidneys over here. We got the right kidney that we can see. And then in this anterior view, we can see the size of this massive abdominal aortic aneurysm. And folks, people may walk around with an aneurysm like this, probably pretty uncomfortable, and they may have intense pain, but they may walk around with something like this for 2 or 3 months. But I tell you, if they walk through our clinic doors, we got to be really good at picking up on these signs and symptoms, like the ones that were presented in the question stem. Because if that blows, right, if that aneurysm ruptures, that's it for that patient. And so take a look at the red box here, and what are, some of those descriptors. Again, with vascular conditions, we often hear the terms like pulsating and throbbing. It also says here the patient is unable to find a comfortable position. That was pretty consistent with what we saw in the question stem. Males, 6 times more likely than females to have a AAA, and typically age is going to be greater than 60 years. And then there's some other cardiovascular risk factors that are listed there as well. As we continue to review this question, we know in let me bring my laser pointer back up here. We know that the abdominal aorta, the descending aorta, sits right up against the lumbar spine, like we saw on that CT scan. And this slice, you can see where the slice it's taken from. It's probably from about the L1 or L2, but a transverse section through the torso. Everything that is back here in the yellow area is considered to be retroperitoneal. So the peritoneal cavity, we know we have a kind of parietal peritoneum that lines the abdominal wall, and then we have visceral peritoneum that lines the organs. But behind the abdominal cavity or the peritoneal cavity are these structures that we describe as retroperitoneal. And so any structure that is retroperitoneal can potentially masquerade as low back pain, as musculoskeletal low back pain. Again, that's what this evening is all about, is identifying these masqueraders. So how many of y'all, and you can raise your hand or give me a thumbs up or something like that. How many of y'all heard of this mnemonic before? SAD pucker, right? So SAD pucker is a mnemonic that describes all those structures or those organs that are retroperitoneal. So the suprarenal glands or adrenal glands, they sit right on top of the kidneys. You can see the aorta is highlighted there. Part of the small intestine, the pancreas, part of it, ureters, colon, kidneys, esophagus, and rectum. We know that patients with colorectal cancer often complain of low back pain. Patients with kidney stones often complain of low back pain, right? So SAD pucker, whatever a SAD pucker is, right? It's kind of a catchy phrase though. And if we can remember, then disease processes or injury that affect any of the structures that are listed here can masquerade as low back pain or maybe as mid back pain. Okay. All right, so well done on these past two questions, by the way. Y'all are doing great. 75% of you got this one correct. Some of y'all may recognize, if you've taken our 2-day course, some of you may recognize some of the questions. I think we got a couple more that are familiar that are coming up, and then one, we have at least one that I know that is remaining that is not from our 2-day prep course. Let's go ahead and move on and take a look at question number 3. Thank you, Blandina. All right, go ahead and start getting your answers in. We just finished a minute on this one. 10 seconds. Yes, thank you. Yeah, that's Ben, that's good information to share. Yeah, well done. All right, so here are the results of the poll, and you can see it's kind of a split between, ruptured spleen and infectious mononucleosis on this one. We'll go ahead and take a look at some of the key words. So we know this person has left shoulder pain, and they're this teenage athlete. Actually, I believe the person who wrote this question, they based it on an experience they had had with a teenage hockey player. So they had left shoulder pain, but it wasn't precipitated by any type of trauma or injury. So no trauma or injury that the patient could recall. The athlete also notes left upper quadrant pain. So when we think of the quadrants, so the abdominal quadrant, so left upper quadrant. And we do know that the spleen lives in the left upper quadrant, but they've got a number of other findings as well. They got a persistent sore throat, they've got fatigue. The physical therapist examination of the left shoulder is unremarkable, but when they palpate in the left upper quadrant of the abdomen, it is painful and it reproduces the shoulder pain. So, yes, a ruptured spleen could account for the left upper quadrant pain, and it could account for the referral of pain to the left shoulder. But there's a little bit more that we've got to take into consideration here, like the fact that this person has a sore throat, they have fatigue, they've got enlarged lymph nodes as well, right? So where we palpate when we're thinking about somebody having some type of illness or infection, they've got some enlarged lymph nodes in the anterolateral aspect of the neck. The correct answer on this one is actually infectious mononucleosis, right? So the person that has mono or that has a bad infection, the spleen becomes involved because it's part of the lymphatic system, but it's also part of that immune response. And people that have a really bad infection that can lead to splenomegaly or enlargement of the spleen. That can push up against the diaphragm, and that can refer pain to the left shoulder. So typically, somebody that, for those of you who answered a ruptured spleen, there's going to be some kind of trauma that is involved. And but getting back to kind of the question, there's this whole multitude of symptoms that are being described here, which make infectious mononucleosis a better answer to consider. So several weeks, yeah. So Kelsey, yeah, I think that's a good point. The fact that this has been ongoing for a while would make you think about the potential development of splenomegaly. And yeah, Amanda, yeah, that's kind of what I was talking about. So ruptured spleen is going to be is we think about that being more traumatic in nature typically. So a couple of information slides to go with this one. Yeah, we certainly want to make sure to review the abdominal quadrants or the quadrant system. We want to know what organs live where. Typically, anything that lives in one of the upper quadrants of the abdomen can refer pain to the ipsilateral shoulder. And if we're thinking about the lower quadrants, yeah, if we got disease process that affects something in the lower quadrants, we're thinking about pain that is going to be referred to the low back, sacral, groin area, or even into the thigh. All right, so as far as the question goes, yeah, spleen, we see spleen, that's going to be part of the left upper quadrant. And then in terms of referred pain, yeah, so here's the spleen, and we can refer pain up to the left shoulder. And some of y'all have probably heard of this before, but Kerr's sign or Kerr sign refers to irritation of the diaphragm that and with referral of pain up to the shoulder region. Again, historically or classically, people have associated Kerr sign with a ruptured spleen, but it could occur due to any type of diaphragmatic irritation. All right, so well done. That was a little bit of a challenging one, right? And uh, any further questions on that one? I see y'all's comments down at the bottom there, so good points. All right, we'll go ahead and I think we just got two more questions to do tonight. So here is number 4. Go ahead and get your answers in. All right, so while y'all are finishing up getting your answers in, and I think just about everybody has responded. So um, Basil or Basil, hopefully I pronounced your name correctly. And yeah, so what do we do if we've never heard of the condition and the choices? Uh, one tip in terms of answering so hopefully your preparation is going to be to the point where, any of the answer choices that pop up are going to be conditions that you're familiar with. I I teach during our 2-day course, and we have a question that deals with somebody that has a leg problem, and one of the answer choices ends up being the correct answer choice ends up being an acute muscle strain that involves the gastrocnemius or the gastrocsoleus. The way the question is described very well could have been an Achilles tendon injury or an Achilles tendon rupture. But then one of the incorrect answers is popliteal artery entrapment syndrome, which does exist, but it is so obscure and so rare that if you see an answer like that, something that is incredibly obscure, you're thinking, man, I don't ever remember talking about that in PT school. That's not going to be the correct answer, right? So I'd go ahead and mark through that, and I would look elsewhere for the correct answer choice. Um, and my other comment about that is, when people write questions for the NPTE, uh, you, they can't just make stuff up, right? Every answer is supposed to be um, something that is legitimate, like popliteal artery entrapment syndrome. That does exist. It's just so obscure and so rare that that's unless it's really clear cut that that's what they're getting at. It's unlikely that that's going to answers like that are going to be the correct ones, and those would be the first ones that I would strike through. So I don't know if that answered your question or not, but that's kind of the approach that I would take with that. So on this one, so yeah, 93% of y'all chose answer number 3. And let's go ahead and bring our keywords in. So insidious, anytime we see the word insidious in a question stem, we should really be thinking that this is not a musculoskeletal problem that we're dealing with, right? This is something that is more sinister. I mean, I guess it could be musculoskeletal from the standpoint. It could be, uh, a cancerous tumor that involves the skeletal system or the musculoskeletal system, or neuromusculoskeletal. But more than likely, if you see the word insidious onset, then we're thinking about something that is related to systemic disease, visceral origin, something that is not neuromusculoskeletal in nature. Okay, so in this case, insidious onset of sharp, severe low back pain that radiates around the waist and towards the genital region. And our PT examination or assessment of the spine and hips was unremarkable. Symptoms were reproduced only by manual percussion over the costovertebral angle. So, right, just this kind of this tap where the 12th rib, the costovertebral angle, where the 12th rib meets the spine. So what is the action the therapist should take next? And the correct answer was what most of y'all chose, renal calculi. Another name for that is going to be kidney stones, right? So this is a classic description or classic presentation of somebody that has kidney stones. And going back to our diagram and everything, you can see where some of those pain referral patterns are gonna occur for somebody who has kidney stones. So let's take a look at the tips of the green arrow. Again, you often hear flank pain for somebody. That would be this kind of lateral pain just above the hip. And somebody that has a kidney stone and radiating down towards the genital region. I want to share a paper with you that I came across recently, and I didn't even know there was something that was called the Journal of Pelvic Obstetric and Gynecological Physiotherapy. So that's a British publication or a publication from the UK. But in there, and you can see it says common pelvic masqueraders. So there's that masqueraders word again. But the nice thing about that paper is, or the takeaway for me, is this table that talks about common visceral referral patterns for pelvic and abdominal organs. And so I encourage y'all to go ahead and take a look at the paper. I'm not going to spend a whole lot more time running through this table. You can see for the kidney, it says loin pain or flank pain, lateral buttock and thigh pain, lower abdominal quadrant, groin pain. And so Brandon, your question, ipsilateral side only, or can it present contralateral on percussion? I think if we do that percussion technique properly, if we're located at the costovertebral angle, if it's clear that we're on one side, I think it should be ipsilateral only. I think if we get a little bit heavy-handed, or maybe we're a little bit sloppy, and we actually hit over the spine, then we may get a little bit of contralateral sided symptoms. But what we should not see is reproduction of what the patient is complaining with, everything that's in the red box there. We shouldn't see that on the contralateral side. We should see their primary complaint only on that ipsilateral side. Okay. Or maybe what you're asking is, if you do percussion on the contralateral side, can that reproduce the patient's symptoms? And Um, I don't know about that. I've never seen that reported. I know that, for the person who has low back pain and the disc herniation and they've got a radiculopathy, we talk about the cross straight leg raise test. I don't know that there's this crossed percussion test in the case of somebody that has kidney stones. And yeah, and certainly, okay, good. So the way I answered the first part of your question, yeah, I would not expect you shouldn't see if the person has kidney stones on the right side and you do that percussion test on the right side, you should not see reproduction of symptoms over on the left side. Right? Should only reproduce the symptoms that patient came in complaining of. All right, so 93%, well done, folks. I'm going a little bit over time, probably taking a little bit long with my explanations and everything, but here is our last question of the evening. Okay, go ahead and finish up. All right, let me go ahead and share these results with you. Um, yeah, so Basil, so yeah, specific descriptors of cancer. I I guess it depends on when you say specific descriptors of cancer, it kind of depends on the structure that is involved. And if we're thinking about the spine, for instance, masqueraders of back pain, then some of the classic things that come to mind would be pain that is constant. Um, as far as night pain goes, right? Pain that wakes the person up from their sleep and maybe keeps them from getting back to sleep. Um, and yeah, it really kind of does depend on I know I'm leaving a couple out. I'm kind of thinking about this question that is coming up. Let me pop back and answer that. Some of y'all can probably chime in when we're thinking about, metastatic lesions or cancerous lesions, those kind of things. There could be signs of systemic illness, right? Malaise and fever and other symptoms as well. But um, okay, last question here, number 5, and y'all can see there's a little bit more of an even distribution in terms of your responses. So most of you were deciding between hypoparathyroidism and hyperparathyroidism. Let's bring in some of the highlighted words here. So diffuse complaints of diffuse joint and muscle pain. They also have a history that includes kidney stones. During the examination, the PT notes that the patient appears to be drowsy and it takes a long time to process and answer questions. So maybe there's some kind of potentially some kind of confusion or cognitive involvement as well. And so I'll jump ahead and show you the answer, and then we'll talk about why that is. So hyperparathyroidism. So excessive activity of the parathyroid. So um, yes, yes, I was just about to share. Here it is. Look, did you read ahead and look at my slides? So awesome. So yeah. So very good. I'm glad that you know that. So moans, groans, stones, and bones that goes with hyperparathyroidism. So awesome. So yeah, so moans goes with mental problems. So the M's go together. Mental problems such as confusion and poor memory, groans because of the joint pain and muscle pain, uh, and gout potentially, something like that, maybe abdominal pain, kidney stones because of hypercalcemia, and we'll come back and talk about hypercalcemia in just a minute. So excessive levels of calcium circulating in the bloodstream. And then bones are often affected in the form of either decalcification or potentially pathologic fractures. So that's a great mnemonic to remember. And Maha, I hope I'm pronouncing your name correctly, but yeah, thank you for chiming in with that one. And yeah, I had that mnemonic sitting in the on deck circle right here. So remember what are the hormones that regulate blood calcium levels? It's going to be parathyroid hormone and calcitonin, or what I like to think of is calcitonin, calcibonin, right? If we want to keep calcium in the bone, well, what calcitonin does is it inhibits the activity of osteoclasts. Parathyroid hormone stimulates the activity of osteoclasts, which are like, little Pac-Men that are going to kind of chew bone up and break it down and dissolve it, and it'll circulate within the bloodstream. But if we get too much of that, if we get too much calcium, if we get hypercalcemia, then that can lead to all the symptoms that are being described here. This table is from our review and study guide. I know on the slide it says up there it's 2023, but I think the table number is the same for those of y'all that have it, the 2024 version. And there's Dr. Scott Schaefer has put together a wonderful table that talks about a number of different endocrine disorders. This is just some of them, but it's really kind of one-stop shopping for the major or common endocrine disorders. And so I won't go through all of that. I just wanted to highlight that as a reference to you. And the moans, groans, stones, and bones, that all kind of fits in with what we see within in the signs and symptoms package that is right there. All right. And so with that, that is our very last question of the evening. And just in summary, right? We talked about we really focused on some of the smaller body systems tonight. They do comprise about 20% of the NPTE, so 37 questions total. But of those 37 questions, most of those are going to involve evaluation and differential diagnosis, recognizing signs and symptoms and features and characteristics of diseases. So be prepared for that. And that's really where you want to focus your study efforts. I would review the abdominal quadrants, the contents of each quadrant. I would review viscerogenic pain referral patterns and and then know the characteristic signs and symptoms of disorders that affect these systems. Then special tests, things like Kerr sign, Murphy's punch sign is that percussion test, like for kidney stone. McBurney's point or McBurney's test, that'd be for appendicitis, and same thing with rebound tenderness. Rebound tenderness. So those are all some items and special tests that you're going to want to be familiar with. So I have enjoyed this last hour or so, a little bit more than an hour. I see y'all saying thank you in the chat box. You are very welcome. Yeah, thank you all for joining us. And you can see my email in the bottom right here. If you want to email me with questions, then I'm happy to help you prepare for the NPTE in any way that I can. You don't want to go into the exam with any questions unanswered. And with that, if y'all don't have any additional questions, we are going to go ahead and wrap things up. Good luck to those of you who are going to be taking the examination coming up in October. And some of y'all are going to be taking the examination in January, but good luck to each and every one of you. And thank you again for joining us tonight. So the email, yeah, if you can't see the email, let me go ahead and write it in the chat box real quick. And you can copy it from there, and I'll stay on the line just a few seconds for you to, there's my email. And yeah, the recordings are going to be posted on TherapyEd's YouTube channel. So TherapyEd's PT YouTube channel. Okay. All right. So hopefully y'all got the email now. And yeah, again, good luck and have a good night. And thank you for your comments.